Thank you. I'm delighted to present my talk today, Taking Action Against Weight Stigma, Recent Policy Initiatives and Next Steps. I'm Bryn Austin, professor at the Harvard Chan School of Public Health and Boston Children's Hospital. My assignment for this talk is to provide a rationale for using policy to reduce and prevent weight stigma and discrimination, and also to share exemplar initiatives underway to address weight stigma in employment, education, healthcare, to promote institutional change. My aspirations for this talk are to convince you that to advance evidence-based policy, health professionals, including researchers and clinicians, must become versed in the methods of strategic science and policies to reduce weight stigma. And diverse stakeholders, which can include researchers, clinicians, advocates with lived experience, all have unique and essential roles for success. So I'll organize my talk in 3 sections. Part 1, I'll give you a brief introduction to Striped, my program, and the equity framework we're working with. In Part 2, I'll talk about strategic science, policy translation arc, and also I want to address a common assumption about evidence. And in Part 3, I'll bring it all together with 3 exemplar Striped initiatives addressing weight stigma and discrimination. So beginning with Part 1, Striped and the Equity Framework. Striped is a research and training program based at the Harvard Chan School of Public Health and Boston Children's Hospital. Striped stands for the Strategic Training Initiative for Prevention of Eating Disorders, a public health incubator. Our mission is to train the next generation of health professionals to harness the power of public health to prevent eating disorders and related problems with food, weight, and appearance. We strive to create a society where girls, boys, and people of all genders can grow up at home in their own bodies. And all of our initiatives are motivated by a commitment to advancing health equity. So what is health equity? And for this, I'll turn to a wonderful publication from the Robert Wood Johnson Foundation. They write, quote, health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and the lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And I want to add one more layer to this to think about intersectionality. So how can we pursue health equity through an intersectional lens? And for this, I'll draw on a publication from the National Academy of Medicine, where they write, quote, this kind of health equity approach with an intersectional lens means, quote, approaches that are attentive to the ways in which systems of inequality interlock to create conditions for either health equity or health inequities. So for the framework that we're using and that I will come back to several times during this talk, relying on the work of Dr. Kumanika's equity-oriented prevention framework. Many of you may be familiar with this. The goal of the framework is to guide selection of interventions to reduce disadvantage and improve equity. And we're going to focus in the upper right quadrant there for policy and systems change interventions. And zooming in more, there's 3 areas I'll give examples of in Part 3: promotion of unhealthful products, threats to personal safety, and discrimination or social exclusion. But I want you to hold that thought because I have more I want to share with you before we get to Part 3. So we'll come back to this. Now, Part 2, this is where we'll talk a bit about strategic science, the policy translation arc. But first, what I want to do is take a closer look at a common assumption about evidence. So why strategic science? There's an unspoken assumption of many scientists about evidence. We study for years, we spend our careers learning how to accrue the most rigorous evidence. We have levels of evidence of how rigorous they are. Like in this pyramid here, we work for our whole careers to accrue evidence. And then the common assumption is that this evidence will lead to policy change. And the assumption goes further that it will be through some kind of direct and unmediated pathway. We accrue enough evidence and policy will change, or so the assumption goes. But what is this pathway? We also train for years and spend our careers studying pathways, excavating them, illuminating how cause and effect are related. So what is this pathway from evidence to policy in the assumption? Could it be osmosis, maybe magic, or sheer brilliance, which I know many of us would like to think, but in fact, reality is more complicated. And I'm going to walk you through the steps of the policy translation arc now. So beginning with step 1, accrue compelling evidence. Step 2, generate viable policy options. And step 3, energize political will. With these 3 steps, there we have an idea of a policy translation arc that makes more sense in reality. So I want to take a moment here to introduce the idea of strategic science. Now, many of you are familiar with the work of Kelly Brownell at Duke and Christina Roberto at University of Pennsylvania. Several years ago, they published in a Lancet an important piece introducing the idea of strategic science with policy impact. And they write, quote, strategic science is research designed to address gaps in knowledge important to policy decisions derived from the reciprocal flow of information between researchers and policymakers. And I would just like to offer one change there to include clinicians and advocates with lived experience in that reciprocal flow of information. And they go on to write, strategic science is communicated not only in scholarly publications, but also in forms relevant to policymakers. And again, I'll add to that, relevant to clinicians and advocates with lived experience, another crucial aspect of this. So now going back to the policy translation arc and strategic science, now introducing that, what has it got to offer us? I would say for step 1, strategic science helps us understand what kind of evidence will be compelling to policymakers and community members. Step 2, strategic science helps us consider the viability of the policy options we generate from the point of view of policymakers and community members. And for step 3, strategic science helps by motivating policymakers and community members by engaging them in agenda setting from the beginning. The collaborations are ongoing and start from the beginning of the process, and that helps to motivate people to follow through and to help to energize political will. So when we can follow these steps with the policy translation arc, that's when we can get to a place with evidence-based public policy. Okay, great, but then where do we get started? And that's what brings me to part 3 of my talk, bringing it all together. I'm going to demonstrate through several examples how we follow the policy translation arc and use strategic science with my program Striped to advance our work on weight stigma, to address weight stigma and weight discrimination. And again, you'll get used to seeing this now, referring back to Dr. Kumanyika's equity-oriented prevention framework, which we know is designed to guide interventions to reduce disadvantage and improve equity. In that upper right-hand quadrant, the focus is on policy and systems, and you'll hear this again too, to guide interventions of different types. Now, I mentioned that there's several categories within this upper right quadrant of policy and systems change interventions. We're going to start with discrimination and social exclusion. How do we address those? So the first equity problem of 3 I'll address today, discrimination and social exclusion, and an equity solution that Striped is working on is to pass laws to ban weight discrimination. And we know weight discrimination is widespread. It is legal in most places, and it is an obstacle to basic rights and health. Bringing in the policy translation arc, we're going to do this systematically, step by step. Recruit compelling evidence. We know that's the first step. So what evidence do we have? Well, the evidence is clear. Weight discrimination is widespread and it worsens health inequities. Much of the research has been led by members of this society. Rebecca Poole and many others have been out front of leading research on weight discrimination and presented at this conference. So I know many of you are familiar with this research and the findings. Just so we're on the same page, stigma defined as disparaging associations of negative personal characteristics with people living in larger bodies. This discrimination, the stigma are well documented to occur in employment, in education, in healthcare and public health, in public settings, and more. Weight discrimination, so widespread, and we know that it is linked to a number of adverse health and mental health outcomes, and also impacts on employment and other sectors of life, arenas of life. So experiences of discrimination are linked to lower earning, people being less likely to be hired or promoted, more likely to be fired, lower subjective ratings from teachers and college admissions, even when objective ratings are equivalent, inaccessible public settings and social isolation. And we know that discrimination is directly linked to depression, to anxiety, to eating disorders, and to the harmful physiological effects, the impacts of stress and allostatic load. The research is clear, and many members of the society have produced this research and presented it here at this conference. So I mentioned public health, and in public health, we have a lot of work left to do to address where we're doing stigmatizing type activities, and much more we could do to reduce that. This is one publication, a research study using the Delphi method from Stripes. You can find it at our website at this bit.ly or QR code. What we write is that research is mounting showing the pernicious effects of weight stigma on health. As public health professionals, our responsibility is to root out the practices and systems that perpetuate weight stigma. So that takes us to translation, the translation arc step 2. So our responsibility is to root it out. Well, how do we do that? What are viable policy options? So with that, there's also been a great deal of work and by members of the society also. There's clear precedent in US law, and I know in laws in other countries too. In US law, we have the Age Discrimination and Employment Act. This could be used as a model to have similar legislation to ban weight discrimination. Other precedent, US federal and state civil rights and anti-discrimination law. All across the country, there's laws like this. Weight protections could be added to existing law. And then a third option, the Americans with Disabilities Act, or ADA, at the federal and state levels. There's pros and cons to this strategy, and it's much debated, but it is another option that has been considered. Now, important to know, and again, this is led by members of the society here, Rebecca Poole and her teams and others, there is strong public support and public health support for making change. So in repeated public opinion surveys from the Rudd Center show that the public overwhelmingly supports action. Nearly 80% of the public support protections in employment law, nearly 80% support civil rights protections. Now, from the Delphi study that Stripe did, I mentioned to you, the public health professionals who participated in that study voiced strong support for action. In this case, more than 90% supported intervention at the macro level, so the systems level, with the business sector to reduce weight stigma. So there's more opportunities there that show widespread support. So we also have made some progress. Some progress has happened already. I've described that to you. In the US, 12.3 million people living in the US live in areas where there are weight anti-discrimination laws. They are protected. 12.3 million people in the US are protected by weight anti-discrimination laws. An additional 1.9 million people in the US are living in areas where they're protected by a court ruling. However, that still leaves us with a lot of work to do. What this means, adding up those millions, mostly that's white in the circle here, in the pie chart here, over 95% of people in the US live in areas where they have absolutely no protection against weight discrimination, over 95%. So I'll tell you a little bit more about where these are. You're probably curious. You'll see in the orange states, Washington State, that's protected by a court ruling for people at higher weights. Michigan, it's statute, state law protecting against weight discrimination. The places in green with the yellow stars are cities. So there are 6 cities that have enacted protections against weight discrimination, those 6 cities. You'll see there's a lot of white on this map. Those are places without protection. So to quote the Rudd Center's weight bias policy brief, they write, without laws to prohibit weight discrimination, people will continue to be unfairly fired, suspended, or demoted because of their weight, even if they demonstrate good job performance and even if body weight is unrelated to their job responsibilities. So that brings us to step 3 further. What more do we need to be thinking about for energizing political will? In Massachusetts, we have a bill in the state legislature to fight body size discrimination in the state legislature. You can read more about it at our website, the QR code or the bit.ly here. Through this work, we're always working in coalition with lawmakers, researchers, clinicians, and advocates with lived experience. These coalitions can help in advising on legislation, amendments to satisfy diverse stakeholders. And the critical piece here is constituents and community members with lived experience. This facilitates the appeal to lawmakers, and it's human nature. The constituent story is always more moving and more motivating than the research data we present. We need the data to inform policy, but it's the stories that will motivate policy change. So in Massachusetts, we're working with Senator Roush and Representative Wynn on the act to prohibit body size discrimination. And then there are ways for you to get involved, whether you're in Massachusetts or not. The first is, if you are in Massachusetts, you can get involved with our work, reach out to us, or you can take this work to your state. The community organization support letter that we're putting together has many organizations signing on, addressed to lawmakers saying we want to see this law this legislation taken to law. You could also, if you're thinking about doing this work in your state, check out the striped playbook, advocacy playbook on our website. We have a step-by-step plan for how you can build momentum for a campaign in your own state. And we're happy to talk with anyone who's interested. You can check it out on our website with this QR code or the bit.ly there. Now, you might be wondering, where could coalitions of researchers, clinicians, lawmakers, and advocates with lived experience get bills filed in 2022 to protect against weight discrimination? That's next year. Where can we get bills filed? Well, if you remember the map I showed you, it's really just about everywhere. Michigan's the only state that has state level statute. So anyone listening, you may have opportunity in your own area. Get in touch with us. Now, I want to move to the second example, working again from Dr. Kumanyika's equity-oriented prevention framework, the example of promotion of unhealthy products. So for this, the example I'll give you from striped work is taking on the dangerous weight loss supplements industry. So what we know, and some of you may be familiar with weight loss supplements, almost all over-the-counter diet pills on the market today are dietary supplements. These products can be deceptive, dangerous, and they also can include the products sold for either promises of weight loss, or you'll see more recently cleanse and detox, but similar kinds of products. These products are predatory, as I'll explain, and they profit from weight stigma. So we'll start again, going through this systematically with the ARC steps 1, 2, and 3. So starting with the translation ARC step 1, accrue compelling evidence. What evidence do we have? Well, we have quite a bit of evidence about these products and how predatory they are in profiting off of weight stigma. They are not effective. They are not effective in a safe way, and there is no medical evidence to support their use. In fact, they are not required to provide any evidence of effectiveness or safety before these products go to market. They are prospectively linked with the onset of eating disorders. They can cause a wide range of health problems, some life-threatening, especially due to adulteration with undisclosed ingredients, excessive stimulants, laxatives, diuretics. These products often will have sibutramine, fen-phen, or other undisclosed medications. This is not legal, but they're ending up in these products. And they also worsen health inequities by ethnicity, household income, gender. So we know from research, national research done with adults trying to lose weight, we find that African Americans in the Latinx community have much higher rates of using these potentially dangerous weight loss supplements. We see higher rates of use in low-income households compared to wealthier households. We see higher rates of use in people with less education compared to those with higher education. We see twice the rate of use in women compared to men, and emerging research shows higher rates of use in transgender and gender non-binary populations. Very recent research, what we're finding since the start of the COVID-19 pandemic, is that African Americans have 3 times the risk of using these potentially dangerous weight loss supplements compared to white adults. Now, this is not by accident, as health inequities never are. The industry targets Latinx and lower income and immigrant communities. Weight loss supplement manufacturers have been hit with multiple lawsuits and US federal charges for predatory targeting of Latinx communities, deceptive weight loss claims, pyramid schemes, also known as multi-level marketing, targeting immigrants and lower income communities. So this is a deliberate drivers of inequities. So let's move to the translation arc step 2, generating viable policy options. What do we do after we accrue compelling evidence? We need policy options. For that, we teamed up with health law expert Jennifer Pomerantz, as a leader in food law. Some of you may be familiar with her book, Food Law for Public Health. So working together, we carried out several legal research studies related to health law and would give us ideas for how we can manage the situation. Published several papers on this and came to the conclusion that from a public health perspective, these products are much like tobacco. We don't sell tobacco to minors, so why do we sell them diet pills? And like tobacco, US cities and states have legal authority to act. We can ban the sale to minors like tobacco. We can move the products behind the counter in stores like pseudoephedrine. We can increase taxes on the products to drive down teen use because we know teens are very price sensitive. So that brings us, we've got these viable options, that brings us to the policy translation arc step 3, energizing political will. So our work is not done, we've got more to do, energize political will. So we've written quite a bit about this. This is an article you can find in Harvard Public Health Review about our work to energize political will at this QR code. Again, as I mentioned before, we always work in coalitions with lawmakers, researchers, clinicians, advocates with lived experience, and in this case, youth. A lot of youth we're working with to advise on legislation and to bring the stories front and center with lawmakers. As I mentioned before, the evidence can inform policy, but it's the stories that motivate policy change. We need that motivator. We're working to support a bill and provide the research evidence and stories for a bill introduced by Representative Khan in the Massachusetts State Legislature and Senator Rush, a bill to ban the sale of weight loss supplements to minors in the state of Massachusetts. Now, I always get to the question, what can you do to help with this campaign to address this issue? You can get involved if you're in Massachusetts or want to get involved in Massachusetts, get in touch with me. We're also working in New York and California. We've got active legislation in all 3 states. Or you could begin in your own state to do this work. We've got the support through the Strike Advocacy Playbook, and I'm always happy to talk with folks. We have a community organization support letter. If you want your organization to sign on, get in touch with us. You can see the letter here at the QR or the bit.ly. We also, as I mentioned, we're working with a lot of youth. The youth are leading a survey. The purpose of the survey is to help to amplify youth voices. If you work with youth and want to pass this along, you can find the link to the youth survey here. And also, if you work with youth, we have a youth support letter. Again, the youth are wanting to amplify their voices. The youth are organizing this. They have a support letter. This is to share with lawmakers so they know youth are speaking out on this issue. So that brings me to the third example. Again, Dr. Kumanika's equity-oriented prevention framework, the example of threats to personal safety. And for this, I'm framing threats to personal safety as being barriers to care, barriers to healthcare. So an equity solution is to eliminate barriers to care. And for this one, I'm going to present an idea that's really still in the idea phase. I'm not going to go through all 3 steps of the policy translation because we're not there yet. But I hope you'll bear with me while I present this idea and give it some thought to the questions that I raise. So an easy part for this is that I'm sure that most of us would agree identifying and mitigating barriers to care within the healthcare system will be critical to improving access and quality of care for people with higher weight. I think this is easy for probably most of us to agree with that. We want to eliminate barriers to care. What's not so easy to agree on is what these barriers are and how do we mitigate them. That's where there's a lot of questions still. So what I would like to do, put it up here on the screen, universal weighing, and I'll explain that in just a moment. I want to ask the question, could universal weighing or the widespread use of weighing or BMI assessment actually be a barrier to care? And what do we know so far about this practice, really a routine practice? What do we know so far to help us understand what's happening here? So bear with me. What I'm going to suggest we do is a SWOT analysis, and I'll show you that in just a few minutes to help us ask the question, what is universal weighing doing in our communities or our healthcare setting? And we'll come back to this in just a moment. But first, I just want to explain what I mean. I'm using universal weighing as shorthand for routine weight or BMI surveillance. And this is something that is ubiquitous in our society throughout the country and worldwide. It's routine in primary care. It's promoted by the U.S. Preventive Services Task Force and the CDC and many others. It's in EHR platforms. Routinely, they are collecting height, weight, or BMI, and these are fields that often must be filled in. It's incentivized by payers that these data are collected. It's in school health screenings. It happens in health promotion interventions, in health centers, community groups, online apps, and trackers online. They are including BMI surveillance. And in clinical and public health research studies, a lot of BMI surveillance happening there. So let's go back to the SWOT analysis and see what is that going to tell us about universal weighing, as I'm using it as a shorthand, tell us about that and how that may relate to weight stigma. So to make sure we're all on the same page, just want to give you a little background on SWOT analysis. It's widely used in healthcare, public health, and business. Many of you are probably familiar with it or maybe used SWOT analyses yourself. SWOT, the letters SWOT stands for strengths, weaknesses, opportunities, and threats. And it relates to both factors that are internal to a program or external to that program or organization. It's a systematic process to assess factors that can help or harm a project or to undermine or promote the chances of success. So let's get back to the SWOT analysis and walk through the idea of universal weighing, or that is weighing weight and BMI surveillance being so routine. So we'll start on the left side, which is the top left quadrant, is internal factors that are strengths. So many of these might be running through your mind right now. BMI or weight specifically is needed to dose a lot of medications, especially with children. It's critical, BMI is critical for tracking child growth to make sure kids are on a healthy track. It also can be very important to target equity efforts, okay? These are internal strengths. We're just walking through the SWOT analysis here. So the next quadrant, lower left, these are external factors that might be opportunities. By having a BMI surveillance, we are able to be alert to impacts that might be happening out in communities or across the country in different areas. The surveillance allows being able to detect that. It allows also monitoring of trends in society and monitoring inequities. Okay, so we'll call these external factors that are opportunities using the language of the SWOT analysis. But let's go to the right side now, in the upper right quadrant, weaknesses. Just a couple I want to mention. We all know BMI is a very poor proxy for individual health. Now, it's promoted this way widely in the press, online, and many people think it's a strong proxy for health, but we know it's not. It also takes a lot of resources. If we have this widely deployed BMI surveillance system or universal weighing, that means that it's staff time, that it's resources, equipment, all of this is collecting data, but we're not using all of that data. It's collected so much more routinely than it's used. And in fact, often when people are weighed in medical appointments, that weight is not needed for medical decision-making in that appointment. So there's some downsides there in terms of cost and resources, time, money. And let's go to the bottom right corner. These are threats external to the program. Anything that we do in medicine and public health, anything that we do is in the context of pervasive weight stigma. What that means is that every act of universal weighing, every bit of BMI surveillance is in the context of pervasive weight stigma and discrimination that we've already talked about. This leads to avoidance of care, delayed care, subpar delivery of care, and exacerbate shame for people who are struggling with body image and struggling with body shame. I want to give you one quote from a well-known writer in the field. Probably many of you are familiar with the work of Aubrey Gordon, writer who penned a column for Self under the name Your Fat Friend. She wrote, "I had good insurance and plenty of doctors nearby. I had all the access I needed, but there was just one problem. I was fat, and I couldn't seem to find a doctor who would take my symptoms seriously. So for the better part of a decade, I abandoned the medical care that had long since abandoned me." She writes, better part of a decade, she was not accessing care because of the stigma that she experienced. Now, going back to the SWOT, I just did a quick SWOT analysis for you of one way we could think about this idea of, do we need universal weighing to be quite so universal? What do we know about strengths, opportunities, but also weaknesses and threats related to this work? So now I always go to what can you do, where for this, I mentioned this as an idea. I appreciate you bearing with me to think this through. So let's ask the question, what can you do? First thing I would suggest is conduct your own SWOT analysis. Where, how, and why do you do routine weighing? Could this be a barrier to care, or could it be stigmatizing for the people who are being weighed or their BMIs being assessed? SWOT resources. So any of you want to pick up on this, SWOT analyses are very easy to do. You can get free resources from the Minnesota Department of Health at this bit.ly, or from AHRQ, this bit.ly, and many other resources online. Another thing you can do is to fill out a very brief, in fact, it's one question survey we have on the Striped website. You can get this QR code or the bit.ly, where we ask the question of where routine weight surveillance is happening, so we can get a better handle on all the different kinds of sectors and settings where it's happening. I'll give you one more example of an internist based in Washington, D.C., who described to a reporter from the Washington Post a couple of years ago how she approaches this question of whether routine weighing needs to be as routine as it is. What she says, quote, "I delay weighing new patients so I can make sure doing so would not cause harm, like in the case of clients with eating disorders or a history of body shame." So I appreciate you bearing with me, that idea. I hope you all will give it some thought on whether it relates and how it relates to your own work. Now, getting close to wrapping up here, Dr. Kumanika's framework here, I gave examples from Stripe's initiatives of 3 of the main areas she identified for policy and systems change interventions. Examples I gave: one, to pass laws to ban weight discrimination. Second example, to take aim at dangerous weight loss and so-called cleanse and detox dietary supplements. And third example, to eliminate weight stigma-related barriers to care, and it gave specifically the question of whether routine weighing needs to be so routine. I want to leave you with a few concluding thoughts. As a reminder, I said in the beginning, my aspirations for this talk was to convince you that to advance evidence-based policy, health professionals, including researchers and clinicians, must become versed in the methods of strategic science and policies to reduce weight stigma. And also that diverse stakeholders, that's researchers, clinicians, advocates with lived experience, all have unique roles and essential roles for success. Whether I succeeded in that, I will leave to you. I want to offer you a final challenge. Thinking ahead to your life over the next month, what is one thing you will do to get involved in strategic science and policy advocacy to address weight discrimination? And how will you make that happen? I'll leave you with my favorite quotes from Dolores Huerta, U.S. labor leader and civil rights activist. She says, quote, "Every moment is an organizing opportunity, every person a potential activist, every minute a chance to change the world. Let's change this world." Thank you.